Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Alcohol Use Among Girls and Young Women. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel throughout the presentation. If you continue to experience poor computer audio, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website within 30 business days. To access the recording and PowerPoint and additional materials, please go to www.fada.org, then to our Resource Center, and then to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as a part of registration remains confidential. Statements of credit will be posted 30 business days after the evaluation closes. For persons completing the evaluation and attending the full webinar, completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that your email address you use when you registered for today's webinar must match your email address listed in your FADA profile, as this is the way to connect your statement of credit with your profile. Please note that the evaluation will close midnight on Tuesday, October 25th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site. If you are certified with the Florida Certification Board or a license outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you did not attend the entire webinar, and we are not permitted to provide partial CE credit. Worsham L has nearly 15 years of experience empowering diverse populations of vulnerable youth and their families in medical, academic, residential, and outpatient substance use and child welfare settings with trauma-informed care. L is a licensed clinical social worker and a certified trauma family professional. She is the co-founder and CEO of Lotus Trauma Care, a Southside Chicago trauma provider. L is an adjunct lecturer and field consultant at the University of Chicago in the Crown Family School of Social Work, Policy, and Practice. She received her bachelor's in psychology from Loyola University, Chicago, with a concentration in child and adolescent development. She received her master's in social service administration from the University of Chicago, specializing in the treatment of complex trauma. Elle is passionate about educating professionals and caregivers on the impact of complex trauma and has trained over 1,200 professionals across various social service settings in trauma-informed care. And now I'd like to welcome our presenter, Elle. I'll turn the presentation over to you.
All right. Thank you, Rebecca. Hi, everyone. I am really, really excited to be here with you all and to share this passion of mine. Thank you all for your commitment to serving young women and girls. So let's go ahead and get started. You heard a little bit about my credentials, but I also want to tell you about the person because I really don't think about all of those credentials when I consider what we're doing and why we're here. I'm here as a passion. This work is a calling for me. So when I was about 14 years old, having experienced my own experiences of complex traumas, my parents abusing substances and many other things going on, house fires and all types of really fun things that were overwhelming and stressful, I found myself experiencing anxiety, insomnia, and depression. But I was flying underneath the radar because I had good grades and I was well behaved. So one night I'm just staring at the wall of like a line of shoes. I have a shoe fetish and I'm thinking, how did I end up walking in these shoes? And the answer that I received was to help children and youth like myself. At that time, I had no idea that I would also assist and support the inner children of adults. So I have a number of years of experience working with youth, adolescents, and adults in the process of healing complex trauma. And so I'm really excited to share my passion with you all today. But before we do that, I do want to engage you all because I am not about talking at you all afternoon or all morning. And so what I would like for us to do, if you're comfortable in the chat box, I'd like to just check in with everyone. So if your mood and energy level were a forecast, what would it be? If your mood and energy level were a weather's forecast, what would it be? For myself, I would be sunny because I'm excited to be here with a little bit of cloud because there's a lot of things happening in my life right now. However, it would be sunny with a little bit of cloudiness. So if you would feel comfortable, you can use the chat box to drop how you're feeling, what your weather forecast is. When I like to check in with everyone because when we understand what's going on for us, that is a very, very significant portion of doing this work in a sustainable fashion, but also in implementing trauma-informed care. If we don't feel comfortable, that is okay too. So we have sunshine with a cool breeze. We have some overcast with the cloudy, sunny and calm, sunny but chilly, sunshine in the cool air, little cloudy as I'm recovering from a cold. We have some cloudiness, sunny and warm, partly cloudy, sunny with a slight chance of rain, cool and breezy, a storm watch with clear skies now, sunny, partly cloudy and cool air. There's a drizzle, some sunny with some drizzles going on. Sunny with the possibility of a tornado watch as the day progresses. And so we have a number of different forecasts going on, and it seems like we are all here to enjoy the day in spite of what our forecasts are looking like. So I thank you all for sharing your forecast with us. We have optimistic, getting sunnier by the minute. Awesome sauce, sunny and cold, cloudy and chilly, sunny. Awesome. Keep them rolling in. You can check out in the chat box what your other peers who are also joining us today are experiencing. And for those of us who just joined, we're just checking in the chat box. If your mood or energy were a forecast, what would it be? It is so, so important for us to just check in with ourselves and check in with our energy levels so we can do this work sustainably and we can have realistic expectations of ourselves throughout the training and throughout the day. So I thank you all for your participation. And we are going to now go ahead and get started and review what it is that we are going to discuss today. So our time this morning is going to be spent looking at the intersection of trauma and substance use for girls and young women. So how does trauma influence the initiation of substance use? Once we look at that, we'll begin to understand and recognize the different risk factors that are contributing to substance use and how we can then begin to respond to these risk factors in ways that are trauma informed and that are promoting resiliency and healing and healthy emotional regulation. So when we look at the literature of what the early use and implications look like, we're going to kind of take a peek at literature review first. So literature review kind of looks at a number of different studies at once and kind of condenses a lot of different studies and the findings to help us see at a kind of like a big umbrella view of what's going on, right? So when we look at the literature review, we found that youth who used alcohol prior to the age of 15 were reported to be 4 times more likely to meet criteria for alcohol dependence at a later stage. Furthermore, they found that early use was associated with a more frequent use, higher numbers of drinks, and a dependence in adulthood, in addition to mental health challenges and social challenges. They also found that there is a correlation between post-traumatic stress disorder or post-traumatic stress symptoms and following traumatic experiences that was correlated with the initiation and use of girls and young women. Furthermore, there was a finding that 78.2% of youth between the ages of 13 and 18 consumed alcohol by later in adolescence, whereas 15.1% of these people who or youth who consumed alcohol later on were also, were also meeting the criteria for alcohol abuse. So what does this tell us? This tells us that post-traumatic stress symptoms and the earlier initiation of the use has a correlation with a challenge in adulthood as young women of using alcohol and possibly abusing alcohol. So when we look at a longitudinal study that looks at 3 different waves, what this means is that they interviewed the individuals at 3 different points of times, and they looked at a sample in South Bronx as well as in San Juan, which is a metropolitan area, and Puerto Rico. So we're looking at Puerto Rican descent, and what they found that what they're looking to observe is, one, is there a way to understand how childhood traumatic experiences and PTSD and alcohol use are all correlated. So we want to understand, what is the relationship between childhood experiences of trauma, PTSD, and initiation of alcohol use. And what they do is they further investigated and observed the relationship of these 3 things and how we can use the risk factors to further understand how these things are correlated and work together with one another. So they collected data through several ways. They looked and measured alcohol use, they interviewed parents and youth, and they also measured trauma and post-traumatic stress disorder symptoms using evidence-based scales. The parental interviews assessed parental mental health, substance use, parental monitoring, parental discipline, maternal warmth, and supportiveness. The reasons why the focus was here is because these are some of the protective factors that we have found against adolescent substance use. And so they wanted to measure an understanding of how the protective factors / risk factors, right? Because if we have low ends on some of these things, it becomes a risk factor, versus if we have more of things such as supportiveness and maternal warmth, then those things can actually work as protective factors. And so they're looking at what are the factors as it relates to the family system and the parent-child relationship that impact substance use. The youth measures, on the other hand, looked at sensation-seeking behavior, antisocial behavior, church attendance, and social demographic factors. Again, these are measures and different factors that have been found to be correlated with the substance use and young adolescents. And so they wanted to see, how do we use the previous literature on what we know to be risk and protective factors, and understanding how PTSD symptoms and childhood experiences with trauma show up in our initiation and use. Connection is breaking up. Okay, is connection breaking up for everyone?
No, we can hear you fine.
Okay. All right. Sorry, hon. All right. So if it's okay, I'll go ahead and continue. All right. So what did they find? They found that the presence of 5 or more post-traumatic stress symptoms was a much stronger predictor of substance use or alcohol initiation than the experiences of trauma itself. So what does that tell us? It points to the fact that substance use and trauma specifically is a subjective experience, right? And it lends to and hints to the fact that if there are certain protective factors that exist, the experience of trauma itself would not immediately be the reason why someone will use substances, specifically alcohol, in order to manage, right? It also found that youth with experiences of trauma but had few PTSD symptoms had similar reports of initiation of youth that had no experiences of trauma. So at baseline, when youth were between the ages of 10 and 11, the median age was 11.5. They did use a sample of both boys and girls. However, they found that there was no gender differences between the girls and boys in the early use and the earlier initiation of use. And so what we're taking away from here is understanding what we need to be able to recognize in the post-traumatic stress symptoms, as well as the different risk factors that can indicate that a youth or a girl, young woman is at risk for using or abusing alcohol. So let's look at how do we recognize these DSM PTSD symptoms, saying the PTSD symptoms themselves are the larger predictor of the substance use initiation. So there are four different types or four different areas of symptoms that we'll go through one by one. The first is re-experiencing. We only need one symptom in that category in order to meet PTSD. Avoidance is the second category, also only needing one symptom in this category. The next category is change in mood or thoughts. And this, you need two symptoms. And then we have arousal and reactivity. And this is also two. So we're now going to go through each one specifically as we kind of think more about how and what we're looking for and what we're recognizing. So re-experiencing is the experience of having flashbacks, distressing memories, bad dreams, intense or prolonged mental distress after a trigger, or intense or prolonged body responses to a trigger. And so I want to stop here just for a moment to explain how these post-traumatic stress symptoms end up manifesting. When any person experiences a stressor, our automatic nervous system is activated, and it is responsible for a lot of these symptoms that we're going to look at. And many of these symptoms and re-experiencing are done by or responsible for, are initiated by the sympathetic branch of our automatic nervous system, or our fight and flight responses that we see. Is it just for ET? I'm not sure what the acronym of ETOH is. We have a question, is it just for ETOH or just other substances as well? But this particular study that we looked at was around alcohol use specifically. Alcohol is ETOH. Okay, that's good to know. We're using the molecular. That's pretty cool. All right, so this is what re-experiencing looks like. So if they're telling you that their memories are popping up, or they're worried about things, or maybe they're having nightmares that they're expressing, or maybe there's like constant worrying and rumination, or repeated thoughts about something that's happening in the moment. And then that intense and prolonged body response may look like an increase of our heart rate. It may look like tension in our muscles. Sometimes it's nausea or pain, because the sympathetic branch of the automatic nervous system also activates our inflammation in our bodies as well. So the pain and some of these other body responses are also present because of the automatic nervous system being responsible for our physical health as well as our emotional and mental health. The next category is avoidance. And this is where we're literally kind of thinking about our flight responses, attempting to stay away from people, places, things, events, anything that reminds them of the traumatic experience. It can be thoughts, it can be feelings, it can be sensations, it can be a tone of voice, it can be phrases. And the reason why we find ourselves avoiding just about anything that our five senses can pick up is because when we're experiencing overwhelming stress, our brain is not processing things in the normal way where it then like files things away in our long-term memory. But instead, what happens when we're in the middle of experiencing overwhelming stress, our brain will begin to compartmentalize things into our implicit memory, which means that it's based off of our senses. And the reason why is because if our brain's number one job is survival, using our five senses is much easier to pick up those cues in the environment quicker so that it can protect us. And so this is why triggers can happen at any point in time. And this is why we're avoiding things that seem silly to avoid, because our brains have perceived this tone of voice or this emotion or this object to be associated with the overwhelming stress or the traumatic experience. So both the intrusion and avoidance symptoms, we only need one. How can we help to assist them and reduce avoidance avoidance behavior. Yeah, so we are definitely going to get to, in the latter half of our time today, looking at some trauma-informed responses to help manage avoidance. And a lot of it is helping to provide psychoeducation around them understanding why they're experiencing what they're experiencing, right? So we want to reduce the shame around having any of these experiences in the first place, because there's nothing wrong with anyone for having post-traumatic stress symptoms. In fact, their brain is doing what's necessary to help them survive. So providing that psychoeducation is really helpful because it reduces the shame, which is often a barrier to the process or whatnot, but then also began to pair with understanding their cues of how they know they're in distress, how they know that they're triggered, and then we're going to help them to utilize different coping mechanisms outside of the alcohol that can help to reduce the activation in the body. Because oftentimes substance use is an attempt to regulate the internal experiences that are overwhelming based off of our external experiences of life that are extremely stressful. That was an excellent question. Keep them rolling in. I love questions. So the next category is our change in mood and thoughts, right? So what this looks like is that there is a change in how not only my mood, like am I feeling depressed, am I feeling high, am I having trouble experiencing joy, but it also looks like how do I begin to see the world, myself, and others. So what we might want to notice is trouble remembering key factors or features of the traumatic memory. Again, remembering that when we're experiencing overwhelming stress, the way our brain is filing away memories, there is going to likely be some pieces that are missing sometimes, or other times it's like we're overly aware of all of the memories, right? It's going to be contingent on the individual's internal and external resources. There may also be negative thoughts about themselves, other people, or the world. So this may look like it's my fault. I am worthless. I'm horrible, right? Or other people that may be having some big feelings of distrust. People are out to get me. No one is good. The world is a horrible place, right? And so what ends up happening is when we have experience or witness, and what's really important is that trauma can happen from us witnessing something, not always being something that happens directly to us. When we have witnessed or experienced something that has caused an overwhelming stress and it impacts our view and perspective of the world, it is because our brain is hyper focused on negatives at times in order to protect us. And so when we've had a redundant experience of negativity, our brain begins to overgeneralize our experiences, and our brain is picking up on words and actions and cues and situations that reinforce these expectations of the world, ourselves, or others. And so part, again, is helping our youth, the parents, to understand what these symptoms are and why they're present, so we can reduce that shame, so that we can help them to then use different strategies and skills to help shift a lot of the impact that trauma can have on our thoughts and on our moods. Distorted cognitions can look like blaming ourselves. It was my fault. Maybe if I hadn't gone there, then I wouldn't have been assaulted. Or it may look like feeling as though I'm not going to tell anyone about what happened to me because I don't want the whole entire family to be angry with me, or to ruin the family dynamics. And so there is a perception in our thoughts that the cause or the consequence has somehow been our particular fault. And so it makes it it's like a preoccupation in our thoughts and in our processes around not wanting to engage with anything that reminds us of these triggers, because of how our brain has perceived the process and the situation in and of itself. The change can also look like feelings such as guilt, anger, or shame. It says distorted. This is the language from the DSM, although it's not distorted, right? It is essentially an overwhelming experience of negative emotions or lower energy-based emotions, because that has become so overwhelming and that has become the focus, and it's often reinforced by the thought processes, because thoughts impact our behaviors and our moods as well. And so there is oftentimes environmental factors that are reinforcing these feelings of shame, guilt, and thought, as well as thoughts reinforcing these thoughts or intense emotions of anger, shame, and guilt. And so these are not the only three that can be present, but essentially what we're looking for is there a persistent emotion that is present that is not what is considered to be a quote unquote positive or desirable emotion. We also have loss in enjoyable activities. And so it may look like some depressive-based mood shifts and changes, having a feeling of being detached from other people, which is a form of disassociation in some ways, where we kind of feel disconnected from some people. It also speaks to the impact on attachment that trauma can have, where the quality of our relationships are compromised, and or because we have not ever had an experience of healthy relationships, and we know this to be one of the risk factors coming up later, then we may find ourselves feeling distrustful of other people, feeling unconnected to other people, or literally just not wanting to engage with other people, avoiding relationships because of the anticipation of disappointment or hurt or being rejected, etc., depending on what the individual has experienced for themselves. Remembering that trauma and overwhelming stress is a subjective experience, so real or perceived threats are going to be extremely important and extremely imperative for us to respond to. And then we have the inability to experience positive emotions, right? And so I'll use a case example of working with, and it's typically, this happens oftentimes later when you've had decades and decades of complex trauma, but it can also happen with our children and the youth as well. And so when we're looking at these symptoms, we're thinking of youth 6 years of age on up, okay? And the inability to experience positive emotions is like, outside of interest in enjoyable activities, maybe I no longer feel joy. Maybe I'm no longer feeling excited, right? So there may be a parent telling you that they used to be really excited about a particular hobby such as art or basketball, and now not only do they not want to engage in them, but they're no longer interested in even talking about them anymore, right? And so this can be experiences of a shift in the change in our moods and our thoughts because of the way that the traumatic experience or the overwhelming stressful experience has impacted our perspective of the world, ourselves, or other people. The next category is arousal. This is the final category. These latter two categories, you need 2 symptoms. The first 2 categories, you needed 1 symptom to meet criteria for PTSD. However, seeing post-traumatic stress symptoms in and of itself is what we want to pay attention to. If we think back to what the earlier study said, the symptomology of itself was a higher predictor than the experience of trauma itself, right? So it speaks to understanding how has the child and the youth and the family responded to the trauma and been functioning to the trauma afterwards when we know that there is an experience of trauma. So arousal looks like being easily startled, so being like very jumpy, perhaps, right? Or feeling tense or on edge. This looks like, being a bit anxious, maybe a little bit irritable, difficulty sleeping. Insomnia is very, very common. I mentioned to you earlier around my experience as a youth having insomnia. I definitely had some post-traumatic stress symptoms as well. And angry outbursts and irritability. And so, again, what happens when we experience these? These are typically the reasons why youth are coming to us. Is like when they're having some more of these arousal-based symptoms because they are more problematic in the sense that they're maybe, being disrespectful to their parents, or perhaps they are really irritable and on edge and things, and so their parents are concerned. But again, what we want to remember is that these different stress responses or post-traumatic stress symptomology is a response of the automatic nervous system being activated in our bodies. And everyone, regardless of their age, their gender, or any human variance that we can find, will and can have an activation of their stress response system when they experience trauma or overwhelming stress. We're going to talk more about what that is and what that looks like, right? So kind of just giving an overview of some PTSD symptoms, right? Avoiding thinking of the trauma, avoiding talking about the trauma, right? We have more concentration being challenging when we think about the challenges and the mood and thought. Excuse me. We talked about all the others here or whatnot. So essentially, PTSD symptoms are the body's response to a loss of safety and overwhelming stress. And the intentions are to help us to survive or protect us from those experiences happening again and us being hurt from those experiences. Okay. So let's look at the different types of trauma. So I mentioned earlier that trauma is a subjective experience. So when we're looking at the different types of trauma, we're doing so because we want to think about the intensity and the frequency and the duration of the experience of overwhelming stress. Trauma is the experience of overwhelming stress and specifically the activation of our automatic nervous system. And so when we are sitting with our clients and working with the youth or young women, we want to have an understanding of what experiences they may have had, because the more chronic the experiences of stress or the more overwhelming the experiences of trauma is, the more likely that we'll have some of those post-traumatic stress symptoms that we have seen to be predictors of initiation of use. So the first type of trauma we're looking at is acute trauma. And this is when there's a single incident that has a start and end date. It may look like a car accident. It could be a surgery. It may be a house fire, right? It's something that has a specific start and end date. And it's what we consider to be an acute trauma because the intensity and frequency is not super high. The duration is not super high. It does not mean that it's not going to cause post-traumatic stress symptoms. It does not mean that it's not going to be traumatizing. It just means that there was a single incident where we can pinpoint an end date and begin date. And when we think about the cases and the work that we work in, depending on where we work, and I actually want to kind of check in with everyone in the chat box, what settings do you work in? So that as I'm kind of giving examples, I can speak to the particular settings that you may find yourselves in. Are you in child welfare? Are you in substance use treatment, outpatient, inpatient? Are you in community organizations? Use your chat box to let us know where your population is. You have school-based therapists, rape crisis center, community mental health, organization, detoxing adults only, DJJ adolescent girls program, outpatient, jail center, okay, jails. Okay, great. Thank you for this. Foster care system. All right, excellent. So many of us receive a big file, right? Or may receive a history for our clients of their history of trauma. And so if we have the ability to kind of know what the history is, maybe there's a psychosocial assessment that has been passed to us prior to, or an integrated assessment when we're working in child welfare or with families who have experience of child welfare, then we sometimes have an understanding and a backdrop of what the traumatic experiences have been. And so when we're looking through the file or when we're listening to the experiences based off of our interactions, we want to be able to kind of pinpoint whether or not a person has had an experience of overwhelming stress. So acute trauma is a single start and end date. So I've given some examples, and I would like to now engage you all to kind of throw in a few examples of what an acute trauma may look like, one that has a start and end date. Again, the examples were fires, the ones that I've given. Want to hear some more from you all. Fire, a surgery, a car accident. What other examples of potential acute trauma can be present that we might see? A car accident, a parent illness and death, rape, yes. Animal attack, miscarriage, earthquake, yes. Family member death, traumatic birth, spending time in jail, yes. Traumatic separation. So domestic violence is going to go into our next one. Hurricanes in Florida, yes. These natural disasters, yes. Excellent examples. So some of our examples speak to chronic trauma. So I'm going to explain what chronic trauma looks like. This is when there is a repeated and prolonged exposure to overwhelming stress, right? So like interpersonal violence, caregiving for someone who has a chronic illness, experience sexual abuse, maybe homelessness, right? When we're experiencing repeated and prolonged experiences of overwhelming stress. And oftentimes it comes with a lot of different experiences of being overwhelmed. So let's hear some examples of chronic trauma, something that is repeated and prolonged, where there's not a clear end date and it's just happening for extended periods of time. And in that extended period of time, there is a lot of challenges that come with mental illness. Great example, yes. Gang life, yes. Bullying, stalking, poverty, human trafficking, yes. Power, control, and manipulation, yes. Interpersonal violence, human trafficking, all excellent examples. Incest, yes. Excellent examples. And so as we're thinking about trauma and these really, really horrific things, right? Because oftentimes when we consider trauma, we think of the horrific things. I want us to also pay attention to our bodies, check in with our heart rates, check in with any discomfort or tension we're having, check in with our thoughts and our moods, because naturally, as we talk about these things, we will be activated. And if that's the case, we can simply use our breath. Taking some long exhales can help to slow our bodies down. Taking some longer inhales can help to bring our heart rate up a bit. And if your body is telling you to move, I highly encourage you to do so. So what I'll do is, after explaining these different trauma types, we will go through a relaxation exercise together so that we can stay present with the rest of the presentation, because this can be a bit triggering. Thank you everyone for your participation. If it's okay with you all, I can, let me see what this question is. Curious, when a person meets criteria for more than one type of PTSD, how is that diagnosed? So complex PTSD did not make it into the DSM-5. So as of right now, the PTSD-based symptom diagnosis include adjustment disorder and post-traumatic stress disorder or acute trauma disorder. And the differences are based off of the duration of the symptoms and how and when the specific trauma incident occurred. So for PTSD, it's after 4 weeks, whereas for adjustment disorder, it's after within 6 months. And for acute stress disorder, if my memory is serving me correctly, it's more of like a 2 to 4 week period. And so the DSM-5 kind of helps to provide those more nuanced diagnosis aspects of things as to what's going on. And oftentimes, you all, when we, especially for those of us who are working in clinical settings, we will find that they may not fit into a pretty box of PTSD, and it's really an experience of complex trauma, but PTSD may be the most appropriate diagnosis, even though it's not a single incident of trauma that the PTSD is present for. Those post-traumatic symptom disorders are present for. And so I hope that answers that question. It was a wonderful question. And if it's okay with you all, I'll continue on to complex trauma and what that looks like, right? So complex trauma is oftentimes what we're seeing in social services and what we are experiencing when we're working with people who are experiencing things like poverty, work in the juvenile justice system and the the justice system in general, and the child welfare systems, oftentimes, or in the social service offices. Typically, complex trauma is present and is a factor. So what is it? It's the exposure of varied and multiple traumatic events, right? Which are often interpersonal in nature. So what this looks like is a mixture of acute trauma and chronic trauma all happening in once, right? So maybe I have some substance use. So I'll use myself as an example. My parents abused substances for 15 years of my life. We had a house fire that was extremely traumatic. To this day, smelling smoke will immediately put me on alert where I'm looking for things, right? And the experience of having parents who abuse substances and the unpredictability and the inconsistency that it created and the conditions that they had that created caused a lot of random triggers that end up happening because of the way that your brain processes these different senses, right? And so this again, complex trauma is when we have varied and multiple traumatic events that are happening, and it's a big ball of complexities, right? Where it may be very difficult to pinpoint where the particular trigger is coming from, but it's as opposed to it coming from the generalization of the schema or the belief system that has formed from our experience of complex trauma. Does this make sense to everyone? Okay. Awesome sauce. So if it's all right, I continue here. I'm going to go on to developmental trauma, which is the experience of complex trauma prior to the age of 6. Okay, why is this important? Why is it a distinguishment between these, right? So, and I will say that these are sometimes used interchangeably. However, I like to make the distinguishment because if a person has experienced overwhelming stress prior to the age of 6, that is going to have a much more significant impact on their brain development, on their functioning, and we'll talk more about those different domains of impact in just a second, on just their overall wellness and their overall presentation, because in our first 6 years of life, our brain is developing, it's creating the blueprint and the foundation for the higher level functioning, such as abstract thinking and problem solving and inhibition and impulse control, etc. And so when we think about the bottom-up process of the way our brain is made. What that means is that our brain first begins developing in the brainstem, and then it works its way up through the stages of the brain up to the prefrontal cortex, being the very last part in the front of our head where our brain is developing. Right? Insecure attachment, malnutrition. Yes, those are exactly great examples, Diana, of what developmental trauma can look like and how it can manifest itself. And so when we are experiencing complex trauma prior to the age of 6, and we are developing a viewpoint and a perspective of the world, we're developing a viewpoint and perspective of ourselves, right? Our self-esteem, our self-worth, our how we deal with management, how we identify and express emotions. All of these things are significantly occurring in the first 6 years of our life, when we're largely observing many things, right? How people are dealing with things, how people are responding to things, how people are responding to us when we express emotions, right? So it's not, again, trauma is not only about what we've experienced directly, but it can also be about what we've observed maybe our siblings go through or our mother or father go through. It's also about watching other humans experience overwhelming stress as well. That can also be traumatizing to ourselves, okay? So developmental trauma, I want to give you one more other point that's really important as to why, in addition to our schemas and our beliefs being formed in this time period, the other piece that's really important is that in that first 2 years of life, this automatic nervous system that is we're manipulating when we think about trauma, when we think about stress responses, when we think about treatment and therapy and substance use, the first 2 years of life is when the automatic nervous system is being developed. The automatic nervous system is not only responsible for our emotional and mental wellness, but also responsible for our immune system, our respiratory system, our reproductive system, our digestive system, and all of our major systems, right? And so this is why there's a correlation between physical and mental wellness. Now, when our first year of life, our sympathetic branch, and that's our fight and flight responses, is the first branch that's developing. And so our parents' consistent and nurturing response to us is going to help develop a safe, a healthy response or a healthy system where it's not overly activated, right? Because the parent's response helps to shut off that activation of the fight and flight response. In babies, it looks like needing to eat. It looks like needing a diaper change, the crying and the sleeping, right? And that second year of life, based off of how often and consistently and how our parents or caregivers respond to us, the parasympathetic branch is beginning to develop. This parasympathetic branch is responsible for the off switch of our stress response system, our ability to self-regulate or co-regulate, in addition to our freeze and fawn responses of the stress response system, those depressive factors, the disassociation, the low motivation, the people pleasing, and many other symptoms that we can see manifest itself through trauma. And so developmental trauma, again, is when the overwhelming experiences of stress are happening during a very, very vulnerable period of life. Okay, not to say adolescents that they're vulnerable too, because that's another very significant piece. But developmental trauma is when our brain's blueprint is being created. And that is going to determine the abilities and the capabilities of the next developmental goal for our brain, right? And so what that means is not that people are doomed or that they can't do anything. What that means is that our interventions may need to target some of the other areas that maybe weren't fully developed, such as gross motor skills or fine motor skills, right? Or coordination, emotional literacy. So it just means that if developmental trauma is one of the things we're dealing with, especially in clinical settings, then we want to also make sure that we target some of those developmental tasks that need to be strengthened so that we can help to repair what has been damaged. All right, any questions about these four before I talk about the fifth and final? One that we'll talk about, I mean, we got vicarious traumas, a whole bunch of other types, but all right. So intergenerational trauma is the transmission of post-traumatic stress symptoms and adaptations to offspring. So I'll offer you all this story to kind of describe how those post-traumatic stress symptoms and adaptations can easily be passed down through observation and through, just observation and learning, right? So the story goes as such. There's one day, there's a little girl who's watching her mommy make a pot roast. Her mom cuts off the ends of the pot roast before putting it into the oven. And she says, "Mommy, why'd you cut off either end of the pot roast?" And mom says, "I'm not sure, honey, that I watched your grandmother do it." So a couple of weeks pass, and when she sees her grandmother again, she says, "Grandma, why do you cut the ends of the pot roast off?" And grandma responds, "I'm not sure, baby. I watched my mother do it." Fortunately enough, this young lady was able to have access to her great grandmother. And when she saw her, she says, great grandmama, big mom, why do you cut the ends of the pot roast off? And she said, well, child, it's because when we were living in our house, our oven was too small for the pot roast. So I had to cut the ends off so the pot roast could fit into the oven, right? And so we see 3-4 generations later, there is this cutting of the pot roast without knowing why we're doing it, right? Similarly, there are reactions that we have to conflict. We have reactions we have to other people, reactions we have to ourselves, to emotions, etc., that are passed down through the cultural norms that are created based off of adapting to environmental concerns and conditions that are oftentimes systemic and outside of our control. All right, so do we have any questions about what trauma looks like and why it exists? Yes, and transmission, antisocial behavior can definitely be the same. Yes, 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 right? Because in our context of our families, we are learning everything about how to navigate the world, everything about how to navigate our own internal experiences as well. So if we have not had a healthy model or a healthy experience of being validated, being seen, having safety to be ourselves and express ourselves, then there's definitely going to be some really challenging behaviors that are passed down and oftentimes mistaken for personality traits when really it's a stress response that has become use dependent. Would transatlantic slave trade, 400 plus years of slavery, be considered intergenerational trauma? So the conditions of like distrust for Europeans or distrust for certain systems would be intergenerational trauma, whereas the policies and procedures and things that created that whole process is what we would call historical trauma. Historical trauma looks at the different components of the distress and the disparities and inequities that exist following colonialism. And so historical trauma would be what would help to kind of explain the world Atlantic slave, whereas the behaviors and adaptations that we have in response to that experience is what the intergenerational trauma looks like, right? So another example would be the light skin versus dark skin, like hating the way we look or not liking our hair or not liking our features, our nose or our lips, right? That could be one. Or talking white would be another example of intergenerational trauma, where there is this internalized hatred that has come to exist because the media, the world has been telling us that you are worthless and that you're just property. That is an unfortunate message, but that is kind of what that looks like. So I hope that helps to distinguish the two between the historical trauma versus the intergenerational trauma. So again, the intergenerational trauma is the symptomology and adaptations, the behaviors, the viewpoints, the belief systems that have been passed down. A pregnant woman experiencing trauma, how would this be classified? So it would depend on what the experience of trauma is, right? However, it will also have an impact on the genes, right? Depending on the protective factors that happen following her experience and during her experience, in addition to her experiences prior to being pregnant, are all going to have a significant impact on what's happening in the moment. So if, let's say, for instance, a pregnant woman is experiencing interpersonal violence, it will be looked at as a chronic trauma, right? Whereas, let's say this woman is experiencing maybe it's a horrible incident with the appointment for a prenatal appointment and not wanting to maybe do one of the tests that they're asking her to do. That may be a chronic trauma. So how it affects the baby is that the stress hormones will also impact the baby as well. Additionally, when we experience overwhelming stress for decades and decades, a process of epigenetics happens. And what this means is that our genes we're all adaptable creatures, right? We know and have heard about evolution and how humans and creatures adapt to the environment and the circumstances that we're dealing with, right? And so what could happen is that the baby may be predisposed to some of these stress responses. The intergenerational trauma may be predisposed where they are easily triggered or easily startled, right? So there are a number of different nuances that can kind of go into how the baby is going to be affected and rather the baby is affected, right? But the experience of trauma in and of itself is not a death sentence. It is not a doomsday. What it means is that we have to be intentional about making sure that safety is stabilized and that individuals have the coping skills and coping resources that they need to get their needs met to help mitigate the issues and challenges they're experiencing with trauma. I think everyone has experienced some form of trauma. Would you say the protective factors is what makes a difference in our ability to cope? Certainly, certainly, certainly. The literature says that minimally 70% of individuals have experienced trauma. And I would argue that everyone has experienced trauma, because what we understand trauma to be is an overwhelming experience of complex trauma. What human is not experiencing, overwhelming experience of stress. What human is not experiencing overwhelming stress right now? We've had the pandemic, we have the global shifts going on, we've had this is so much happening collectively in addition to how it impacts our individual households. And so when we have protective factors such as a healthy identity, heritage, like nationality or racial identity, that's a protective factor. When we have hobbies, that's a protective factor. When we have safe, healthy relationships, whether that be with our parents or with another trusted adult, that's something that's a protective factor. When we have access to systems that are of belief, like religious organizations, things of that nature, have also been found to be, spiritual systems have also been found to be protective factors. So the protective factors definitely will determine whether or not an experience of overwhelming stress is traumatic, or whether or not we are able to, and how traumatic it is. Certainly, certainly. Excellent points and excellent questions, everyone. All right, so because we've been talking about lots of trauma and our brains are probably like wheels turning, if it's okay with everyone, I'd like to walk us through a quick calming exercise that allows us to calm our bodies down so that we can continue forward and have with realistic expectations to be present with the rest of the presentation. So the exercise that we'll do today, I think I've done the half salamander with this organization before, so we'll do a 4-4-4 breath. Yeah, we'll do a 4-4-4 breath. We'll do 3 of these breaths. Okay, and I'm going to tell you what it'll sound like so that you have the option to choose whether or not it's something you want to participate in. So the count will sound like this. Inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, and we'll repeat that for 3 times, okay? Now, what's important is that when we are breathing in our belly. So when we inhale, our belly should be inflating, and when we exhale, it should be deflating. The reason why I must repeat this and kind of call attention to it is because the way that overwhelming stress and trauma impacts us is it has us breathing shallow or even holding our breath, believe it or not. And so it's very important that we're intentional about making sure that our breath is happening in our bellies so that it can send calming signals to our ventral vagal nerve, which is the part of our automatic nervous system that shuts off the stress response system, whether it's trauma or a regular stressor. Okay, so if you would like to participate, I'm going to walk us through this exercise. Perhaps you want to roll your shoulders on your back, maybe back or forward. Maybe you want to do a nice neck roll. Whatever movement your body is telling you it needs, trust it. All right, and we're going to begin to inhale for 1, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4, inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4, inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4. Taking a naturally paced deep breath in through your nose if that's available to you, and out through your mouth. Again, allowing your body to do whatever movement is telling you that it needs. Now, thank you for your patience and or participation. Right. So if there are no more questions about trauma, we will go on to look at how help us understand why we're seeing some of the challenges that bring our youth into our offices in the very first place. right? And for those of us who work with adults, young women, everyone, every adult has been a child, right? So every adult, this information is also going to impact the experience of the adults, and and understanding the way that trauma impacts these different areas and domains that I'm going to go through here will also help us to understand why we're seeing some of the challenges that we're seeing with our clients. And so when we understand how trauma or the experience of chronic overwhelming stress impacts our well-being as a human, we're able to then provide psychoeducation to the clients that we're working with, the participants that we're working with, to help reduce the shame, because trauma causes so much shame. When we saw the changes in cognition and mood, right? It causes so much shame because a person is left to wonder, I must be a horrible person or unworthy if all these horrible things keep happening to me, right? It's a fairly reasonable deduction depending on the individual's experience. Additionally, it also gives us a more compassionate viewpoint of why the person is experiencing what they're experiencing. It reduces some of that vicarious trauma of feeling helpless in the sense of being able to help them, when we can conceptualize and understand why they're experiencing the challenge they're experiencing and how we can begin to target these different areas. So what we're going to review now are the different areas or domains of impact of complex trauma or overwhelming trauma in childhood. Now, because the automatic nervous system is being impacted over and over again, when we have chronic overwhelming stress in adulthood, these same areas can be impacted because of the same system being impacted. All right. So the first area will be health in the body. And when I mentioned to you earlier, this automatic nervous system is responsible for our major systems, right? That immune system, respiratory system, digestive system, reproductive system. It helps to really make sense as to why we might be seeing some challenges with people who may have diabetes, high blood pressure, IBS. There's a lot of digestive challenges happening, headaches, inflammation, pain, dementia. Some of these things end up happening because of the impact of the automatic nervous system being switched on, and how it redirects all of the energy that would typically be directed towards the healthy functioning to our fight, flight, and freeze response, so that we're able to fight off the threat. So what's important to understand is that with trauma, or with stress in general, there are different levels to stress, right? There is a such thing as a healthy level of stress, and this is where there's a stressor that presents, perhaps my child is getting ready to go to college, right? And this is motivating me to make sure that we got their school paid for, they have everything they need. But once I get them off to school, I feel good about it. Bittersweet moment. It's a healthy stress. It motivated me to do what needs to happen. And then we have a tolerable level of stress, right? Where maybe we're going through a divorce and we're mourning the loss of our marriage, whether or not we want to be in it or not, right? It's still a loss of what we expected of that relationship. So that tolerable is oftentimes those life transitionary periods, right? Maybe we have finals when we're in school, or we have a transitionary period of our children going from one developmental stage to another. They're teenagers now in 2022, right? These things can be tolerable levels of stress. When it becomes traumatic is when it is chronic and overwhelming, right? So when we are experiencing an activation of the stress response system with no relief or very little relief, that is when things become traumatic, okay? So a trauma-informed lens allows us to recognize how trauma manifests itself, how it shows up, and how it doesn't discriminate against humans, but most importantly, how to recognize the stress responses when they show up, so that we can respond in either a way that promotes post-traumatic resiliency or prevents trauma from happening. Because there's no way for us to know, unless our job allows us to have that, whether or not a person's stress response is related to trauma, right? Because oftentimes a lot of this is subconscious. And the other piece is, we are not trying to avoid triggering our clients. That would be such a unrealistic expectation of ourselves and just cause a lot of stress. And so I want you all to consider triggers to be an opportunity for our clients to heal, for ourselves to heal, for humanity to heal, because triggers will happen inevitably, right? It's what we do with them and how we respond to them. All right, so let's look at thoughts and mental health, right? We talked about cognition and things in the post-traumatic stress symptomology, but we're also thinking about things like having trouble with executive functioning, having trouble concentrating, having trouble problem solving. This may also look like having paranoid thoughts around your safety or the intentions of other people, right? So our cognition, our thought processes, and executive functioning are not working at the highest capacity because of the way in which our brain has spent most of its energy being in survival mode. So the prefrontal cortex has not been developed to its fullest capacity, right? Again, it does not mean a person something wrong with them. There are super, super intelligent people who have experienced all those traumas, right? And yet they still function. So these domains of impact, again, trauma is not a death sentence. It just means that a human is having a natural response to overwhelming stress because of the way that the body and the brain has responded. So our relationship speaks to the attachments, not only the relationship with ourselves, but we may see that a person has a lot of issues, that one of the youth may have a lot of challenges with their family members. There's constant conflict with a family member or a sibling, or maybe they're constantly having like on and off relationships with their friends or their peers, and they don't really have good peer relationships. There may be challenges just across the board with trust of relationships, of intentions and things. So these are when our cognition and our belief system about other people and the relationships with other people have been impacted in a way where we don't feel safe anymore, and that we don't anticipate for those relationships to be safe. And it's very difficult to engage in a safe relationship, a healthy relationship, healthy dynamics. In fact, it can feel like, oh man, are you trying to set me up? Or is there something coming soon? It can put people on guard, ironically. We also have disassociation, which is very, very common when we experience complex trauma, developmental trauma, some of those more intense in intensity and duration and frequency. Disassociation is the brain's attempt to tap out from the experience, rather internal or external, of overwhelming stress. And so we may have trouble with memories, we may have our mind going blank, we may have problems with like recalling things, which is trouble with memory. We may have a lot of like sometimes in dissociation, like the split between personalities can end up happening as well. And so disassociation, again, is an attempt to tap out from the overwhelming experience. And it's very, very common with interpersonal violence, with sexual abuse, and with developmental trauma because of the helplessness that exists in those situations oftentimes. So I want to stop and have everybody check in with their bodies and offer an opportunity for any questions. Okay. All right, so mood and emotional regulation or affect regulation are the youth able to identify their emotions? Are they able to express their emotions, right? Do we have emotional literacy? Do we have emotional regulation capacities? Is there a shift in how we're seeing the world and how we're feeling? Do I feel depressed all the time? Am I irritated all the time? So it kind of goes back to those post-traumatic symptoms that we looked at just a moment ago, and understanding that the mood and emotional regulation capacities can be significantly impacted, where maybe we're being triggered in an instant, where we're going from 0 to 100 so quickly, and the child is not understanding why they're so frustrated or why they're behaving so impulsively. So we have behavior, which kind of speaks to, it correlates with our ability to regulate emotions and things, but it also speaks to gross motor skills. It also speaks to developmental delays, fine motor skills, impulse control as well, in addition to the typical idea of what behavior looks like and our ability to manage that. And then final, but certainly not least, is our self-concept, right? Do I feel lovable? Do I like myself? Is there a low self-esteem? Is there shame? Is there guilt? Do I feel worthy of respect? Self-concept is significantly impacted in the experiences of overwhelming stress. And so when we're conceptualizing and understanding the challenges that our client presents with, hopefully this helps to make sense of how their experiences of overwhelming stress has contributed to the factors and the challenges that they're presenting before you. So let's recognize trauma risk factors, right? I mentioned to you that our automatic nervous system is being activated when we are experiencing a trigger, right? And what's happening with all of those types of trauma, or with any stressor in general, is that there is a loss of safety. And this matters whether it's real or perceived loss of safety, because the same neural pathways are lining up. And so I'm just going to briefly discuss what these safety types look like, because it helps us to recognize when there may be trauma or triggers or stress responses that then help us to understand how we want to navigate these things with the child, whether or not we want to explore further how it's impacted them so we can assess whether or not there are some post-traumatic stress symptoms present. So our physical safety, this model comes out of Sandra Bloom's sanctuary model. She has 4 areas of safety that she identifies as necessary for sanctuary safety and nonviolence, okay? And so what we're doing is looking at these safety types and thinking about it in the inverse of when there is a threat to these safety, how does this help inform the reason why the individual, the child, the youth that we're sitting with is having a trigger in the first place so that we can respond to that and validate that and assist in getting those needs met, okay? So we'll start with physical safety because it's typically what everyone thinks about when they consider safety, right? So outside of like rather not my body is safe, we also want to think about, do I have access to adequate clothing for the weather that I'm in, right? Or am I in tank tops in negative degrees? Do I not have a coat and I'm walking around in a hoodie when there's snow outside? Am I walking around in flip-flops when there's 5 inches of snow? Do I have adequate clothing? Do I have adequate food? Do I have access to adequate nutritional food? Is there a food desert that I'm living in? Our access to food is also part of our physical well-being and safety, in addition to our shelter, right? Am I experiencing homelessness? Did I just get an eviction letter posted? Is this child moving from house to house to house because of transients that's happening with their family members, right? So there are a number of different physical safety threats that can happen in addition to possibly bullying, right? If there's someone is pushing them around and things, or hurting them or threatening to hurt them, that can be a physical safety threat in addition. So I'll ask in the chat box for you all to share some examples of what physical safety threats may look like for your clients. Homelessness. Mhm. This could look like domestic violence, loss of a job, yes. No access or family knowledge of nutritional foods, yes. Moving around and changing schools, caregiver who lacks protective capacity, yes. Temporary housing, food insecurity, sexual assault. I'm sorry, the person who has hurt you in a sexual manner has access to you. Transmission of behavior on children, yes, like the physical discipline, nowhere to go when in distress. Yes, not having a safe space. Rats at night, yes. Hoarding, yes. All excellent examples. So I'll go on to our next one, which is social safety. We are all social creatures. We need to feel seen and loved to be our best selves, right? And we think about babies, like how, or toddlers, right? They are so intentional about getting a positive response from the person or adult that they're dealing with and engaging with. So it just speaks to how important social safety is. But this is whether or not we feel comfortable being ourselves. Is it safe to be ourselves? And we think about adolescence and childhood, it is extreme. Social safety is a really, really big one. How many likes did I get? Did I not get any loves on or shares on my post? Whether or not I can talk how I talk, can I dress how I dress, can I listen to the music I want to listen to? There are so many things that go into what makes us individuals that sometimes it does not feel safe in a social environment, rather that be with our peers or at home or in our workplace, to be able to respond. So for these youth who are experiencing social safety in the context of the household, maybe it's not okay for them to use, their usual slang or vernacular that the teenagers are using, right? Or maybe it's not okay for them to have the interests that they have because it's not acceptable in the culture that they are growing up in. Maybe there is a problem where they're being picked on because of the music they listen to. So let's hear, social safety is huge in the school system, certainly. So let's hear from the group. What are some examples of what social safety may look like for girls and young women? Especially when we're thinking about alcohol use, right? Like the peer pressure to use. Having access to alcohol. Yes, we'll soon see how that plays into substance use initiation. Using to feel confident. Yes, clothes not being stylish. Access to extracurricular activities to foster interest. Being made fun of for not having. Yes, yes, yes. Feeling accepted. Acceptance of hair. Oh my goodness, yes. Lack of security and validation. Stigma. Yes. We have body type, right? Especially with young girls and boys. Young men are also concerned about these things, but especially with young girls, and that's what our focus is on today. Our body types are also extremely, extremely in the forefront. Am I meeting the standard of beauty? Keeping up with trends, bullying, yes. You have these TikTok challenges nowadays, right? There's so many things that are going on that can potentially compromise the social safety of the youth that we work with. Being embarrassed by their parents, right? Rather that be because of a reprimand or what the challenges of the parents are, how their parents show up to the school. There are so many different, being reprimanded in front of the classroom by a teacher, cultural and traditions for newly resettled refugees. Yes, yes. Social media trends. Yes. Excellent examples, guys. Excellent examples. This is great. So I'm going to go on to moral safety. And our moral safety is when we think about our values. Outdated technology. Yes, that's definitely a social safety threat for the youth. I need the iPhone 12. Moral safety. Moral safety is when our values are not being honored, right? So this looks like when what I'm witnessing, what I feel I have to do, or what I am doing is not congruent with my values, right? So for instance, we don't like the way perhaps a parent is talking to their child or reprimanding their child. There may be an inconsistency in our value system at that point. There may be a moral safety threat for the youth having a particular value on something like acceptance of peers when their parents don't care for that and minimize the impact of not being accepted, right? So there may be another moral safety threat there. So essentially, our values are being compromised. Sometimes it's policies and procedures that we're asked to implement or that we see being rolled out. Other times it may be the laws and systems that we're observing and that are impacting our clients, that our clients are expressing as part of the stressors and the impacts of the challenges that they're experiencing. So I'm going to turn it over to the group again to inquire what might be some moral safety threats that the youth, the girls and young women may experience. Their attitudes about alcohol use in the first place, right? Moral safety threats. Misunderstanding behavior, promiscuity, yes. Normalization of substance use in the home, anger, yes. Trying to fit in with others by doing unsafe behavior. Hmm. So anger can become a moral safety threat when, let's say, for instance, I don't feel it's okay to express anger, right? The value of emotional expression may not be present. What you're expected to wear, underage sex. Yes. So if you have a value of modesty and you're expected to be revealing, underage sex, if you have intentions or desires to be a virgin, but there's all this pressure around you must do it or you're a lame or a square or I can't think of their new words. There's so many new words. Gang duties that may contradict the morals and values to be accepted. Yes. Women undervalued in the home. Yes. Seeing it used as a coping mechanism and adopting that behavior. Yep. Dress and appearance. Yep. We even think about the gender roles, right, of the household that may come up, or even within the peers. Media, yes, certainly. In the media, we see all types of moral safety threats, right? For instance, the injustice of several stigmatized and marginalized groups of individuals globally and nationally. Excellent examples. So this final and last one we'll talk about is our mental or psychological safety. And so this kind of speaks back to the cognition and the thought process and our belief systems, right? So essentially we're considering, and when the child speaks to us, what is their thought process? Is it hurtful or harmful? Are they thinking in a black or white type, either or type of way? Are they thinking that, are they being hard on themselves, right? What they should have done, what they could have done? Are they being mean? So we want to be mindful of the content of their thought processes, because these can be mental safety threats. Are they constantly thinking about what they should have done or what they should have said in a social situation that they just experienced, right? These may be some mental social safety threats. We had rap lyrics, explicit or exploit violence. Yeah, that is definitely a moral safety threat for many people. So let's hear some examples of mental safety threats. What might mental safety threats look like for our youth so that we're able to pinpoint it when we see it? I like that express these things. Always putting themselves down. Yes. Rehearsing distressing events. Yep. Verbal abuse from peers and parents. Yep. Feeling not good enough. Yes. Lack of confidence. People pleaser. Yes. Fear of failure. Yes. Academic underachievement. Yes. Self-esteem issues. Yes. 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 So all these mean comments and judgments on themselves about their capacities, the idea to be perfect. Yes. And so another thing, guys, to think about with trauma is that not being seen or heard by our parents can also be traumatic, right? It's not always just horrific things that are happening. So remembering that the child's experience of overwhelming stress is what may potentially be traumatic for them, right? And it's a subjective experience, and is real or perceived lack of safety that we want to respond to. Expecting the worst no matter the situation. Yep, the person being moody, late development. Yes, all of these are great examples. I'm so excited that you all are able to kind of pinpoint these and recognize how they pop up and may pop up for your clients and the youth that you're working with, right? Because the risk factor here is that there's a loss of safety that's happening, right? And this loss of safety can easily trickle into all of those post-traumatic symptoms that we just talked about earlier. Having adult responsibilities, yes. So many youth are so overwhelmed and anxious about adulthood and about the responsibilities of cooking and cleaning and going to school and like all these things they're dealing with, right? Excellent examples. Excellent examples. Uh-oh. Right. So if it's all right with everyone, I'm going to continue on as we look at the risk and protective factors. So the comparing siblings, favoritism. Yep. Yep. Psychosocial safety / mental safety, because the voices that we hear in our heads are largely the criticisms of our caregivers, our family members, and our peers from childhood, right? So all of these experiences can definitely begin to create this self-talk. Are you supposed to see the comments of others? Yes. For those, some of them are being sent privately by mistake, but you should be able to see the comments of everyone for sure. It says the host and presenter. Oh, I guess you guys can't see the comments. Oh.
They can't see each other's comments.
Okay. No, you can't. Okay, I'm sorry, guys. No, but I'm reading them off. All right, so we'll go ahead and continue with risk and protective factors. And we want to just ground ourselves in the idea of this family interaction theory, because this is used to understand the pathways of abstinence and use of alcohol. And what it does is it's a combination of understanding that the interpersonal characteristics of the youth, the social influences from their peers in their environment, and their emotional attachment to their parents all interact together to determine the child's likelihood of using alcohol and also having an earlier period of use, as well as actually engaging in abstinence. The second piece here is that we're looking at this parent-child attachment aspect of things, looking at the supervision and the quality of the relationship that they have with their parents as well, because those are also a significant factors that influence the likelihood of a youth using substances, especially alcohol. So, risk factors. What has the literature shown us about the risk factors for young women and girls using alcohol? One, parents frequently use, right? So if my parents frequently use and I'm observing that, then there is this belief system that is okay, or maybe that is cool, and we all look up to our parents as children, right? And then we have the parental emotional disorders. So if a parent is experiencing depression or bipolar disorder or anxiety, these things can cause a lot of undue stress and create certain circumstances that may be stressful in the process. Okay. Low levels of parental monitoring. So when the parents are unaware of where their children are, who they're hanging out with, what's going on, their youth are more likely to engage in risky behavior, especially alcohol use. Additionally, poor parent-child relationships have been found to be correlated with these use of substances as well. So what does poor child-parent relationships look like? It looks like there's not any quality time. Quality time does not mean a whole bunch of time. It means whether or not the child feels like their parent cares about them, feels like their parent listens to them, feels like their parent spends time with them, right? So some things we might want to ask is like, do the clients or the youth sit down with their family members a couple times throughout the week for a meal or two? At what point in time do you talk to your parent? What do you and your parent talk about? Some other pieces are the child sensation-seeking tendencies. And so when we think about their temperament and whether or not they are very adventurous, that can also be found as a risk factor because they're more likely to try risk-taking behavior or risky behaviors when they are predisposition to seek adventure and seek these thrills and that rush of dopamine and feel-good hormones. We have conduct problems and antisocial behaviors as another challenge. So when we have the child or youth being labeled with things like antisocial personality disorders or conduct disorders, or just, they're being seen as aggressive or disrespectful, or they're always in fights with their peers, these can be some risk factors. When we think about these things, hopefully you're able to see how there are some safety threats that end up lying within these risk factors that are the reasons why they end up becoming potentially stressful and can have a potential to create post-traumatic stress symptoms that a youth may want to get away from and shift from. I'm going to just come over to the chat box for a second to see. I have a question. Has the ADHD and the differences in how it presents in girls and boys been considered? In this particular study, this is a summary of several different studies, so it depends on the study. Some of them have been considered in the differences in where they present themselves, but for here and the purposes of what we're talking about, I am not distinguishing the differences between the presentation of ADHD, just because that's a whole nother training, and we're focused today on how to understand the risk factors of substance use, and how to then enhance the protective factors so that we can reduce the likelihood that the youth ends up with a lifelong substance use disorder, or initiate too soon or really, really early, or at least maybe there may be some harm reduction in the process of how they're engaging in their use. Excellent question. All right, so the next one here is depression. That low mood, those freeze and fawn responses, low mood, low interest in activities, right? Some of those depressive symptoms also correlate or overlap with some of those post-traumatic stress disorders as it relates to the shift in our moods and in our cognitions. Having unstructured activities where after school it's just whatever you want to do, as opposed to there's activities that you're engaged in, hobbies, right? Extracurricular activities, maybe in the community, perhaps at school, maybe at church. When there are nothing that is really happening for the youth and they're just kind of left to their own devices, as teenagers, as youth, they're naturally going to seek out something that's going to help to get the need met for adventure, for dopamine, for social connection, etc. Then we have the peer use and or the peer promotion. This is also a risk factor. So if the youth that we are seeing are also very likely to be around teenagers or other youth that are using or promoting the use, maybe through music or through hey, we're about to have a party, we're going to have some drinks there, depending on how it is being talked about and sensationalized, it can definitely become a risk factor. And then lastly, we have high stress environments, right? Because of the way that the automatic nervous system gets activated, the alcohol can be a depressant to help calm down. All this energy just feels overwhelming and out of control. So let's look at protective factors, okay? Because it's so important that we look at the duality of these things, right? So with our protective factors, we have the maternal warmth and supportiveness. I'd argue that it can also be adult warmth and supportiveness, right? The literature is looking at the relationship between mom and the dyad. However, we all know experientially, just because the literature hasn't caught up, that healthy relationships with a loving adult that has warmth and supportiveness makes the world of a difference for a child, rather that be a coach or their parents, right? But specifically, when they have a close connection with their parent, their mom, and they feel seen by their mom, they feel validated by their mom, they feel supported by their mother, that is seen as a protective factor, where a less likelihood of early initiation and a higher likelihood of abstinence. Monitoring of their behaviors is also seen as a protective factor. If my mom has my location, or my mom's always calling in and checking on me, or she's randomly, or dad, or randomly, FaceTiming me to see where I am, if asking for the numbers of my friends' parents and their addresses, right? If there's monitoring, there is a little bit less likelihood of the youth engaging in problematic behaviors because of the potential consequences that have. All right. And then we have family rules, right? And structured activities. So we spoke a bit around structured activities that helps to speak to their self-esteem, that helps get their connection and needs met, right? So it gives a environment, a structured environment, so they can get those developmental needs met in a healthy way. Then we have family rules. Family rules about youth, family rules about expectations, right? Is there, again, that structure? When children and adults have structure and predictability, it is a protective factor because it helps to this predictability. When we have so much happening in our lives that is unpredictable, it makes it easier to deal with those unpredictable triggers when we have some expectations of structures, as opposed to it's just willy-nilly and I don't have a bedtime, no one's monitoring me, my parents may or may not be here. So when things happen, it just feels very chaotic. That can become extremely overwhelming. We have family rules. We just talked about that. Encourage abstinence, right? When the parents or the family system are explicitly encouraging abstinence, there is a less likelihood of the youth using. Also having some skills around knowledge of refusal skills, right? So a lot of the preventative programs that you see with youth will teach the youth about refusal skills. It will also teach the youth about social skills as well, so that they're able to be equipped with the skills that they need in order to navigate those really uncomfortable situations, especially when social safety is involved, because of the fear of how we're going to be judged based off of our engagement and the activities that everyone else is doing. And then lastly, we have a high level of anti-drinking attitudes. And this has to do with the family norms. This has to do with the way in which the youth has perceived consequences of drinking, right? There's a number of different ways that a child or a youth can end up with anti-drinking attitudes. Nonetheless, if there is an anti-drinking attitude, for whatever reason it is, that is a protective factor. Okay, I'm going to check the chat box. Oh, okay, so we have another question for everybody about interventions that you may use that promote protective factors, right? So when we consider all of these things that are considered protective factors, what are some strategies or tools that we use that help to target these areas and help to and promote the protective factors? Providing in-home services, linking them to positive structured activities, reviewing the 5 love languages and boundaries within families. Yes, a schedule at home to provide safety, teaching assertive skills, parenting classes, fun after-school events, especially for adolescents, services in the home, parents abstaining from alcohol, safety plan in the home, case management that can help develop lists and tools. Parental involvement in the treatment process is so important, right? Providing psychoeducation to the family and assisting with connecting to resources to address barriers, teaching responsibility, education on alcohol and drugs, expressing emotions, youth church programs, policies that support all youth. Yes, right? The inclusivity, the safety the safety being established, the predictability being established. These are all great ways of how we can begin to target participating in sports, target the protective factors that we know exist for youth, right? We don't always have to focus largely on the risk factors. It's important that we know that they're there, right? And then and some of those risk factors we can actually target, such as with case management, linkage, and things of that nature. We have parent-child autonomy, wraparound services and mentorship, journal writing, music therapy. Yes, giving them some other ways to cope and manage things. Yes, yes, great examples. Great examples. All right, sorry about the duplicate. All right, so what does the literature say about these protective factors? They have power. There are fewer risk factors correlated with the lower frequency of use. So when we have less risk factors, there's less frequency of use, but we also found that when we have higher risk protective factors, higher protective factors, they do not drink as frequently as those who do not have as many protective factors, right? So the lower risk factors, lower frequency using, as well as with our youth who have more protective factors, they're going to drink less frequently than those youth who have fewer protective factors in their life. All right, so everyone should have a handout that has the case study listed. What we are going to do now is spend about 10 minutes looking through this case study and answering the questions that you all have. I'm going to read the case study and then give you all the questions. You should also have the handout available to you as well. So Susan is a 13-year-old referred by her mother. What are we doing? Right? If we go back to your handouts there, thank you for the link, Rebecca. So if we go up to our piece here, what we're going to do, because we're not going to be in small groups due to the formatting, for ourselves, we're going to reflect on what protective factors we see, what risk factors we see, and what particular questions we can ask to explore the risk and protective factors further. So in your handout, it summarizes the risk and protective factors. It also has the case study there along with the questions. So I'll read the case study. Susan is a 13-year-old referred by her mother after the adolescent was caught at a party drunk. Susan told her mother that she was at her best friend's house for a sleepover. Her mother reports that she has smelled alcohol on Susan twice before. When you meet with Susan, she proclaims, "I don't have a problem. I don't know why I'm here. My mom is overreacting." She reports that her mother works a lot, but they are close. Susan explains that her best friend is dating a high school freshman and he invited them to a party. He is on the football team and his cousin got the alcohol for the party. Susan believes attending the party was a good way to make friends, so when she joins clubs, she will know. Susan reports having 3 drinks and that this was her second time drinking. She states that she wishes her body was more like her best friend's figure, who was always getting all the cute boys. Susan reported that she and her mother attend religious services 2 to 3 times a week. Susan's father and mother divorced due to her father's abuse of alcohol. Her mother has a diagnosis of depression. All right, so what protective factors are present? I want to give everyone a few moments to kind of reflect on and look over the case study for yourself, and then we can drop them in the box. Just, some people need a little bit more time to process, and so we'll give a few minutes. We have protective factors as mommy being protective, religious factors, maternal warmth, carrying adult in her life, monitoring, mom is paying attention, she has friends, culture and religion, good relationship with mom's disapproval of alcohol use, sense of openness and communication, having a best friend, natural supports. Let's see, I'm gonna make sure I get everything coming in pretty quickly. Sense of community, She wants to be involved with other people at school and she has friends. Being close with her mom, a bond with her mom. Excellent. Excellent. So next question is, what are the risk factors that are present? What risk factors does Susan have? Parents' divorce, body image concerns, peer pressure, social status concern, divorce, maternal mental health concerns, father has abuse history, mom works long hours, low levels of parental monitoring, depression, mental health, low supervision, stealing. What is stealing? Response to peer pressure, family history of depression. Excellent, excellent, excellent. Body image comparison to mental health risk factor, low self-esteem, seeking to fill a void with boyfriends, association with children who use alcohol, minimizing, needing to fit in, promiscuity. Okay. So these are really great risk factors that are present. And there are some of our identification comes with a bit of things that we're presuming that is happening. So that brings us to our next question around us thinking about what questions can we ask to explore these risk and protective factors further, right? Because there are some things that pop up and we may need to ask some follow-up questions to learn a little bit more to determine the strength of the factor. Being a teenager in transitionary period was another risk factor, and the lack of instruction from mom about alcohol up front. Excellent, excellent, excellent. So what are some questions? Let's get some concrete questions that we can ask of Susan. Ask about if she's feeling depressed. So that might look like, what's your mood like every day? How do you feel each day? What do you know about safe alcohol use? Excellent. What is your typical after school schedule? Excellent. Do your friends consume alcohol regularly? Great question. Yes, keep them rolling in. These are awesome. Do you have goals you're working on? Why does she feel that her body is not as good as her friends? Do you have any health concerns? Do you know the effects of alcohol use? What does your depression look like? Where do messages of alcohol use come from? How do you feel about your experience with your parents' divorce? Yes, yes. Open-ended questions on various topics. I would love to hear about some of those examples. How do you feel about your experience with your parents' divorce? How do you feel when you drink? How does your religion affect your life? How would having a boyfriend fulfill you? How do you feel about mother working a lot? What are your goals? I'd like to hear more about her elementary years in school. Okay, so let's hear some questions about exploration of elementary years. How is drinking alcohol helping you get healthy relationships? How do you feel about the family rules? We said we want to explore more around the risks due to parental abuse of alcohol. How do you feel in your relationships? What happened when you drank? Do you like it? What are your thoughts about drinking and why? Excellent questions. Excellent questions. How often do you consume alcohol? How much do you consume when you consume? How does your father's alcohol use make you feel? Excellent questions. Do you feel suicidal at times? How do you think your alcohol use affects your life? In elementary years, did he have friends? Did she have friends? Seem happy? How did she cope with her parents' divorce? You are so young. Why do you drink? How do you feel when you do not drink alcohol? Excellent question. Have you ever experienced a blackout from drinking? Do a lot of your friends drink on the weekends? Do you feel like you won't belong if you don't drink? How do you feel about the separation of your parents? Who do you know that doesn't drink? Excellent, excellent questions, right? So all of these questions are open-ended questions that get us to a number of different things. Number one, open-ended questions are great to use with youth and adolescents because it gets us a sneak peek into their head, their mind, their thought process, right? Another question is, how does your consumption of alcohol affect your relationship with your friends at church? And did her family receive therapy? The other piece around these open-ended questions is it really helps us to get into the nitty-gritty and the details of understanding how these what perceived to be a risk factor whether or not it's a risk factor, what the underlying pieces are to the risk factor, exploring further her thought processes. We're thinking more about the peers that she's around. We know about her friend, but what are the other friends? I love that question around what friends don't drink, right? Who do you know that doesn't drink? Do you feel like it's cool to drink, right? Getting her perspective and attitude on drinking. So you all are doing a really excellent job of thinking about how to take these questions and look more into how we can explore these protective factors and the risk factors so that we know where we need to target the interventions, where we want to focus, what we want to promote. Another question is, who do you feel safe with? Yes. Do you feel like it's cool to drink? What other interests do you have? Do you have a history of physical abuse? What are your views regarding your social life and your family life? Is there conflict within the two? Great. So we're exploring more whether or not there's any stress happening, her perspective, her mental wellness. We're exploring her perception of her peers, her attitudes of substance use, alcohol use, the peer usage, right? Whether or not her friends are using, whether or not they promote it, how she feels about use, what her information is around the consequences of use. Another question that has come through is, how will looking like your friend improve your self-image? And then the next question is, are you feeling pressure to drink? Right? So some of them are open-ended, some of them are closed-ended, but even the closed-ended questions are great because it immediately gets to the nitty-gritty of yes or no. Is this happening or is it not happening? Any patterns around current drug and alcohol use? Do you feel like adults in your life hear and understand you? Yes. Excellent question, right? Because when teenagers do not feel seen or heard by the adults, they seek that through their peers. These are all excellent questions. Excellent questions. And so if it's all right, everyone, I'm going to move on as we start to look at the responses that we can have and how we can implement trauma-informed care to begin implementing post-traumatic resiliency and to help them to prevent use or practice longer abstinence, or at least have a lesser frequency of use and duration and the amounts that they're using. So I'm reading the chat box. Another question is, tell me about the moments of sorrow or regret after drinking, right? Which is, I like how this question is phrased because it's phrased in an assumption. So the assumption that is happening, that these things occur. So it gives them room to elaborate or to say that it doesn't happen, right? And especially with teenagers, sometimes if you give like a yes or no question at times, or they can, if it feels stigmatizing, right? Or if there's a safety threat associated with the question, if it's not phrased as if it's like as a matter of fact, this is what happens type, you can end up getting like a reporter bias where they say, no, that's not it. So sometimes phrasing questions like this is very, very helpful, right? When we phrase it as a matter of fact, or as like, this is the norm. How often does this happen for you, right? Type of thing, as opposed to does it happen for you? All right. Excellent questions, everyone. Thank you so much for your participation. All right. So what are the components of trauma-informed care? These components come from SAMHSA, which is the Substance Abuse and Mental Health Administration. And what they have found is that 4 components of trauma-informed care must exist. And I love this model because it is able to be used across populations, across settings, across professions, right? And so for first component there is for us to realize the widespread impact of pathways and for recovery, right? And so we talked about how the trauma does not discriminate. We talked about the different safety threats that can arise, that can cause trauma. We talked about the different types of trauma and how that can impact this chronic overwhelming stress or cause chronic overwhelming stress. And so we've also talked about some protective factors that are helpful for recovery. In just a moment, we're going to talk further about how we can use trauma-informed care to help facilitate that post-traumatic resiliency aspect of things. We also looked at how to recognize the signs of trauma. within people as it relates to the post-traumatic stress symptomology that may pop up. We look specifically at the PTSD criteria, but we also talked about those fight and flight responses and how the automatic nervous system and stress responses in general tell us that this is a sign that the activation of the system is on, so that we're able to respond in a way that integrates our knowledge of trauma and stress so we can resist re-traumatizing the youth, and at the very least, not the very least, resist traumatizing them, but also promote post-traumatic resiliency if they have been traumatized and if they are triggered, right? Because again, we cannot avoid triggering our clients, but instead our responsibility and our goal with trauma-informed care is to recognize the stress responses and the trauma or experiences of overwhelming stress when they present themselves, when we're reading it, when we're hearing about it, when it's being expressed, okay? So let's look at engagement and rapport building. So one of the things that we want to do is we're going to pull our clients, the youth, into the ventral vagal nerve, right? For a number of different reasons. Number one, when we pull a person into the ventral vagal nerve, it shuts off that stress response system and it minimizes the likelihood of either re-traumatizing or the stress becoming traumatizing in the first place, right? And so then secondly, when we think about the developmental period of adolescence, right, and how important it is to have a healthy relationship with an adult or with an adult, we are utilizing all of these things, the developmental tasks of adolescents in that ventral vagal nerve, to work together so that we can build rapport, we can engage with them, so that as we begin to treat the substance use, if that is what we're treating, we are able to do so in a way that does not have so much defense mechanisms, and the youth is more likely to cooperate and engage in the process. So the number one thing we want to do is make sure that we are being authentic. You are your best tool. No one can be you. So utilizing your personality and who you are and showing up, especially when we're working with teenagers, is so important. So if you have humor, if you're a little goofy and quirky, like I'm really quirky, and I'm sure y'all noticed that already, right? Be okay utilizing who you are in the room to engage the youth is really going to be extremely important, because it's going to create that safety that's necessary for them to open up to you when you're asking these questions and you're assessing further the risk and protective factors, and you're making suggestions around different interventions with coping strategies and getting them involved with extracurricular activities and working through their self-esteem challenges, etc. And then we have the validation and agency. So we want to promote agency, right? Because oftentimes with trauma or overwhelming stress, especially when we're experiencing the post-traumatic stress symptoms, there is a lack of agency and a lack of control. And with that, especially, and then we think about adolescent development, when they feel in control, definitely. When they feel in control, they are more likely to be present with the process and buy into the process, right? As opposed to, oh, you're just another adult trying to tell me what to do and how to move. You don't understand, right? So that's where that validation comes in. Validation is acknowledging the child's thoughts, their emotions, their beliefs, their intentions, and their values, right? It's not saying that we agree with their behavior, right? So for instance, with Susan, she went to the party and drank because she wanted to make friends, right? So, and a validation was, it's important to you that you know your peers before you get there, right? I'm validating that that was her intention. I'm not saying I agree with her reasoning, right? So validating is letting the youth know that we see them, we hear them, and we're here with them. Normalizing is also important, is what was said. Yes, it certainly is, right? Especially with teenagers, when we are normalizing the developmental tasks of adolescence, of needing to be accepted by our peers, of being concerned about our parents and our peers, of so many things that are going on in adolescence, of having really intense emotions, right? All of these things can really be helpful in reducing shame, and also being able to help to support that process of moving the client, the youth, towards healthy choices around substance use. Another comment is that if you're not authentic, they spot it and will call you on it. They certainly will. And that is like, there's nothing more embarrassing than being called out by a teenager. All right, so we have next the activities and media. So we can use media and activities to engage the youth. We are going to have so much luck, right? Now, and also it's trauma informed, because when we engage with movement, right? When we engage with writing, the gross motor skills, or we're using media through, which is a form of expression, then we are also tapping into that ventral vagal nerve and promoting something called bilateral integration, which is when the left and right hemisphere of the brain is talking to one another, which is something that is absent when we are dealing with trauma and overwhelming stress. And so we're promoting resiliency, and we're also engaging them in a way that's also helping to strengthen the development of their brain in ways that and targeting some of those areas that have been impacted from those domains that we talked about earlier. So here are some techniques that we want to utilize. One, creating predictability, right? So we're all at different settings. So we want to make sure that we're explaining the process of the services and the rules, right? So when I worked in substance use treatment adolescent program, I would literally explain to them, okay, so this is our first appointment. This is what's going to happen. We're going to have to fill out this paperwork. We're going to take an assessment. I'm going to ask you some questions. This is why I'm asking you these questions, right? So we want to explain the process and explain the services and explain the rules. After I ask you these questions, I'm then going to make a recommendation. And this recommendation, blah, 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 right? So you explain what they're going to expect. This helps to minimize the distrust, all that cognitive stuff that we talked about earlier, if there is an experience of post-traumatic stress symptomology. And it also helps to build the safety so that we feel engaged in the process and they feel respected, right? When we know what to expect coming forward, we're not on edge waiting for the next thing to happen, right? So creating predictability is very important. The other piece, in addition to explaining your process, will be like letting them know we're going to do something. So for instance, if you're working in the office with the client and you're going to close the door, maybe letting them know, okay, I'm going to close this door now, right? Or I'm going to come over next to you to that file cabinet, right? So again, creating predictability so there is not much suddenness or unexpected things happening in the moment. And then we have agency, right? Promoting choices wherever possible. Do you want to do this form first or this form first? Do you want to do a red pen or a green pen? Do you want me to write or do you want to write, right? You want to talk about who you are first or you want to get the paperwork out the way, right? You're explaining the reasons for the consents. You're explaining everything and you're giving them agency to sign the consents for their family members, for their parents, and explaining why you want that, right? Yes, giving them autonomy. Ask if closing the door, turning the lights down, or is appointment. Yes, it is. It certainly is. So I don't even have to ask permission on here, but asking permission is so important, right? Can I continue? Is it okay if I go to the next question? Can I ask you about X, Y, and Z, right? Those are, are you cool with me closing this door? Those are really, really great. That's a great point, Carla. Thank you for adding that. Asking permission is another way to create trauma-informed space, because it is giving that not only giving that person agency, but also showing that you respect them. It is adding in that collaborative aspect that is necessary in the process of having trauma-informed care. Using open-ended questions are especially helpful with teenagers because it guides critical thinking, it guides problem solving, and it helps them to begin expressing themselves, which is a major task in adolescence, right? How to begin connecting the dots between what I'm feeling and what I need and expressing that. So these open-ended questions are so helpful. I teach parents to use these all the time, and you'll actually find that they are being a lot more thoughtful in their thought processes than we assume they are oftentimes, right? And so when we want to give advice, we might want to change it to an open-ended question to kind of see where they're coming from and what their perspective is. And we may even be able to get them to articulate it for themselves. So in this process, we're also having those neural pathways light up in their brain so that they're now going to be more likely to kind of use this critical thinking and problem solving and expression out there with their peers and as they grow into young adults. We also want to engage parents, right? We have to engage parents. Someone mentioned that earlier today around promoting protective factors, but engaging parents is going to be so important, right? Especially given that the parents set the context for the environment that the child is responding to in the first place. So the engagement of parents will look different across the board depending on our setting. So I have several ideas you can do so. You may do so through a survey. There are like surveys or parent-child checklists that you kind of get the perspective of what the parent sees with their child. You may just have a couple of questions that you ask yourself of the parent, right? You may do a phone call Within my practice, every time I work with parents, I make sure that they know they have to be involved in their child's treatment, and I empower them to understand that they are the miracle worker in their child's life. They are going to be the one that is going to change their child's life. I am just a co-pilot here, like cheering them on, right? And so you may even bring them into the session. Obviously, you want to ask permission with the teenager and explain to them why they're coming into the session, and make sure that there's some predictability and safety there as well. You may have a parent session where you're just meeting with the parent alone, right? Helping them to have a better perspective, a more optimistic perspective of their child, perhaps helping them to think about how they can engage and create and increase the experience of quality time. If the parent is working, quality time can be having one meal a week together. Quality time can be checking in with them when you get home to see how their day of school went. Quality time does not mean you spend a whole bunch of time with them. It means that you're intentional about the time that you do with your clients, right? Another way to do so is to engage the clients in, like, the parent and child dyad, in interactive activities that they can find joy in, right? So like if we're in school settings, maybe we have like a family fun night. If we are in a substance treatment center, perhaps we have a family fun night there too, where we have an opportunity to help have some positive, healthy interactions, which we know are protective factors. And oftentimes the lack of that is part of the reason why the child is using in the first place. And then this last point is to target our protective factors and to provide resources and skills to address the risk, which you all did an amazing job at when you were dropping things in a chat box around how to respond and what to do, what type of questions to ask and explore, etc. So at this time, I'm going to go over to the chat box to make sure that any questions and things are answered. If you do have any questions, please drop them in the chat box. It says, please let me know if at any time you feel uncomfortable with a question or topic. I can rephrase. Alice, that is awesome, right? That statement there with the youth, like, again, that rapport, that like letting them know I see you, I care, you're promoting agency, especially in a time with adolescents where they feel like adults don't want to hear them and don't respect them, right? That is certainly a wonderful way to engage with them and to create agency in that process. Like, it's okay to assert yourself. Someone else also mentioned that being client-centered, coming alongside them and knowing that they are experts, right? And in their own lives, right? Even the teenagers, letting them know that that you are the expert in your life. And so just to kind of, in the aspect of engaging parents, I know that that's not super comfortable for some people and some professionals. One way that we can do that with the client or with the teenager is kind of explaining to them that, sometimes adults don't really understand teenagers all that much. And so if you decide to release some information and allow me to engage your parent, it helps me to help them see and understand you a little better. And 9 times out of 10, actually, I've never had a teenager deny me after explaining it in that way, right? So I'm going to stop there. There are some resources that we have for you all. The alcohol use among girls and young women, a worrying trend, also by SAMHSA, in addition to additional risk and protective factors that are elaborated on. So I want to open the floor for any questions or comments that we may have as we begin to wrap up. My pleasure, Carla. Says, I'm a CRPSA, but I feel like this class is instructive for understanding adults as much as young people. Yes. Yeah, the information can definitely be across the board. We were all young people, even as adults, right? And oftentimes, especially with trauma, we're stuck in our young selves. This was a great presentation. No questions, but thank you for this awesome training. Oh, my pleasure, everyone. Thank you for your kind words and for your commitment to trauma-informed care and making sure that you're able to engage the youth that you're working with. Like, you are an invaluable asset to the process of their healing, the process of their healthy development. So I want to thank you all for your commitment to the work that you're doing in social services. I want to make sure that you're taking care of yourself. It's very, very important to do. And I'm available if you all have any questions. You can email me at Worsham at Lotus Trauma Care. I'm more than happy to answer any questions that you may have. Oh, thank you, Lisa. Make sure that.
We really appreciate all the work that you put into this presentation, and it was great. You're getting great remarks in the chat. I hope you can see them all. Please make sure you send all of your comments to all panelists so that Elle may see all of your comments while we close out. Thank you again, Elle. And I've got just a few items of business before we conclude today's webinar. Everyone, please see the chat panel for a link to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FADA's website. If you want CEUs or to get a statement of credit for this event, you must complete the evaluation form. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. After you register or sign in, you will be directed onward to the evaluation. You must use the same email address you used when you registered for today's webinar as what you have listed in your FADA profile, as this is the only way to connect your attendance within our profile. We'll get a second opportunity to complete the evaluation through a follow-up email later today. The evaluation will close Tuesday, October 25th. And please know we do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. As well, if you have any further questions about CEUs or statements of credit, we do have a place on our website for questions about CEUs, and you can get all of your answers there. Thank you all again for participating in today's webinar. We'd also like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. And remember, the evaluation will close Tuesday, October 25th. Thank you all and have a great day.
Thanks, everyone.
Thank you, Elle.
Pleasure.